I wish I can grow some bone right now to be a little taller. Yeah, this is a really no, I guess I'm just short. This is not a tall podium. Um, so yes, I've known Dr. Masaki since first year medical school, and at that time I kind of knew I wanted to go into geriatrics. I would have gone to JABSOM had I not met my husband. I had to wait for him at UW to finish, so I figured I'll just get my fellowship done at UW instead. So he was at UW at that time, but come on, I would have joined JABSOM geriatrics if I could. So let's just get started. Um, so does anyone know what age do we achieve peak bone mass? Anybody? Any hands? Can we have a show of hands, maybe like at 20 years old, 30 years old, 40, 50, 60? Oh, yeah, no one says 60. That's good. The timing is based on genetic, hormonal, and environmental factors, but it's widely believed that it's really your third decade. I'm way past my third decade. So so it's all down here from now on. So that's why this topic is really relevant to us, including myself. So conflicts of interest, I really have none. I work for Hawaii Permanente Medical Group, which is associated with Kaiser Permanente. We're going to talk about epidemiology, the definition, signs and symptoms, diagnosis and treatment and approach to osteoporosis. So the prevalence is pretty high. We're talking about over 200 million people worldwide with osteoporosis, and at least 40% are women, and between 15 to 30% are men will have at least one or more fragility fracture. So men are not immune to osteoporosis. Once upon a time, we used to think that men never got it, but that's not true. Approximately 30% of all postmenopausal women are in the US and in Europe. Hip fractures associated with serious disability and mortality. And that's the reason why we talk about it and try to say, hey, how can we prevent it? It's projected by 2050, and that's not that far from now. We're talking about little more than 25 years. We'll reach over 6.2 million people that would have had some kind of a hip fracture. Definition. Definition is basically lone bone mass, microarchitectural disruption, and skeletal fragility. And then this results in decreased bone strength and an increased risk for fracture. A lot of times we don't really talk about this definition because it's really too long. We just go straight to the bone mineral density. And you'll find that when you get a bone mineral density scan, you would be in the normal range if your T-score is greater than less than 1. So the more positive you are in the scale, the better off you are. And the more negative you are in the scale, the worse it is. Osteoporosis is defined as less than 2.5. And severe osteoporosis are those with less than 2.5 of a T-score, and they have at least one fragility fracture. So what are the signs and symptoms? Anybody signs and symptoms? None. You're right. None. We don't know that we have osteoporosis until, well, you look for it through a bone mineral density scan, or you fracture. And that's pretty a painful way to find out. These are just some pictorials of what, fractures could look like. The intertrochanteric hip fractures are one of the more common ones I see in the hospital. I usually get called because some of my patients would have fallen, have a hip fracture, and they get pretty delirious in the hospital. This picture says, this region contains a large amount of cancellous bone with good blood supply. So therefore, they'll heal well and heal properly. I mean, I guess that's the picture for, intertrochanteric hip fracture. Ideally, we want no fracture, right? In the next picture over here, this one here, we're looking at the difference between normal bone and osteoporotic bone. And as you can see on the, I guess this would be both of our right side, the bone looks thinner. It's the spongy part of bone looks thinner, and even the compact bone at the top is also thinner. It's basically, think of bird bones, chicken bones. Birds can fly because they have thin bones. We can't because our bones are much heavier. Next slide. Diagnosis, basically, you could diagnose it with a fracture, fragility fractures specifically in these areas: spine, hip, wrist, humerus, rib, and pelvis. Fingers and toes don't count. Or if you have a T-score of less than 2.5 standard deviations from any area, well, any of these areas, the hip or the spine, with the DEXA scan. When to screen? General consensus: women ages 65 and over, postmenopausal women who are less than 65 years old with some kind of clinical risk factor. And then it's very controversial for men. It's kind of all over the map. In general, if you're 70 and older, it's reasonable to screen. And there are actually various societies and foundations that say, hey, and these specifically Bone Health Osteoporosis Foundation, the International Society for Clinical Densitometry, and the Endocrine Society say, well, that if you are a man ages 50 to 70, with risk factors, maybe we should be screening you. So what are these risk factors? Age, of course. The older you are, the more likely your bones will be thinner. If you had a previous fracture, if you have long-term use of some kind of glucocorticoid therapy, say, for instance, prednisone. We do have a fair number of patients who are on prednisone because of COPD, because they have like other medical issues. And sometimes if you're going to start a prednisone, your endocrinologist or maybe your pulmonologist might say, hey, I think we need to get a bone density scan. Why? Because they want to anticipate what will happen if we start you on steroids, what will happen to your bones, and start planning for that potential. Low body weight. So if you're kind of on the skinnier side, you're more likely to get osteoporosis. If you have family history, that's a really strong one because a lot of it is genetics. How much bone you put on is a lot of it is your genetics. And then these two things are really something that you could actually stop or remove from your risk factors. Cigarette smoking and alcohol use. Both of these can put you at risk for osteoporosis. There are secondary causes: women who go through menopause early in life, men who who are have hypogonadism, they have less testosterone, some kind of malabsorptive disease, say for instance, inflammatory bowel disease, or in some ways that you can't absorb calcium and vitamin D normally, that could put you at risk for osteoporosis. Oh, we can't see this very well. I guess it kind of pushed some things aside. But if you go home and you or whenever, you can actually type into Google FRAX, the fracture risk assessment tool. You'll find that there's this tool for you that you could use online. And you can kind of play around with and see what is your fracture risk. This is a better picture here. So I just put in an age of 68 years old. Let's see here. I guess I always have trouble with this. 68 years old, and this person is a female, happens to have a mother who had a hip fracture, and I just had it do its math, and it says that this person has a hip fracture risk of 3.7% over the next 10 years. So what does that mean? It means that if you have the FRAX score is basically more of a score to suggest when we should treat osteoporosis. If you have a 10-year probability of a fracture that is greater than 20% or greater, or a 10-year probability of a hip fracture that is 3% or greater, then your physicians might say, hey, I think it'd be reasonable to start you on a medication because you're at the higher risk of fracture. Now, look, if you look at this calculator, what I didn't put in is actually this here, the bone mineral density. So if we put that in, then you actually would recalculate and actually further refine the risk score for this patient. Let's see here. So treatment, what are our treatments here? I'm just going to talk about a few, and the mainstay would include oral bisphosphonates, which is alendronate, also known as Fosamax, IV bisphosphonates, also it's called zoledronic acid or Zometa, the rancoligand inhibitor, denosumab, which is Prolia. What's going on? Do I need to talk somewhere, like go somewhere else? Hello, hello, hello. Okay, good. This is a better one. Oh, maybe
There's
not.
still an echo.
Do you guys still hear an echo? Wait, we still hear an echo. Is it like where I'm standing? Like, how about now? 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 Better? Okay. How about now? Now? How about now? Better? Okay. Well, why don't we do it this way? So, RANKO inhibitor. Oh, wait, I gotta get this. So RANKO inhibitor, which is basically denosumab and also Prolia. We'll talk a little bit about that. And parathyroid analog, which is also called teriparatide. Lifestyle, this is something that you can do today, giving yourself some calcium and vitamin D, going out in the sun. Though in theory, older skin, you don't absorb the sun as well. So we do recommend maybe taking vitamin D orally. It's pretty easy. You could eat bushels of salmon skin. I wouldn't do that. But you could do pills. Salmon skin apparently has a lot of vitamin D, but I think you have to eat literally bushels of it. Um, let's see, exercise, weight bearing exercise is specifically swimming is great, but it's more for your heart, less for your bones. So you want to have some kind of bone pounding type of exercise. So weightlifting, some kind of walking, something with weights. The other thing we want to do is, again, stop smoking and another plug for limiting alcohol. This is a very complicated slide, but it can be easily described. So I want you to just focus on A, panel A. Panel A is basically someone who has older bone. Could be postmenopausal for men, just an older gentleman. And the bluish purple cells are called osteoclasts, and those are bone cleaving cells. So think of class as cutting. And then in the background, you see some pink cells. Those are bone building cells called osteoblasts. So you have the human body is pretty amazing. It's always dynamic. You build and you take away. It's a dynamic situation. And what happens is that the body would form bone, but the body will also cut away parts to shape the bone. In an older bone, that process is imbalance, where you actually have less of the bone building cells called osteoblasts, and you have the remaining osteoclasts are still there. They're still working the same rate, the same pace. So what happens? You get thinner and thinner bones. And so what bisphosphonates do is they actually kind of embed themselves, like this medication embeds themselves in the bone and it actually slows down the process of the osteoclast. It kind of tells them, look, you can slow down, maybe go away for a little bit, don't do any work, and let our bone building cells, the osteoblasts, keep up. So the result is in panel C, you see that there is more bone. And I guess in this, you might be able to see this, but it shows here that there is the resorption pit. That's where like the hole is formed from the osteoclast. And then in 6 months later, it shows that the hole is kind of, oh gosh, it kind of gone. So that's basically what bisphosphonates do here. Cost, it's pretty inexpensive. It's actually generic now. Pretty easy. You take it once a week. Side effects includes muscle aches, the infamous osteonecrosis of the jaw. But when choosing this drug, we choose the patient wisely too. If you have a history of some kind of bone cancer, if you have like poor dentition, we don't want to put you at that kind of risk. So we would say, hey, maybe this is not the right drug for you. Hypocalcemia, more often in the IV form than in the oral form. And most patients may complain about, or some patients may complain about acid reflux. And for that reason, we tell you exactly how to take it because you have to be on an empty stomach. And if you eat it with some food, you render it ineffective. So we've had some patients. I used to work with an endocrinologist in my fellowship. And we're like, why is this patient's bone density scan not budging? Like they're taking the medication every day. Well, they take it with their breakfast every day. And so it basically was ineffective. And in fact, they lost years. They spent, several years taking the exact same way. And we only to realize after 2, 3 years that, you took it the wrong way. So how do you take it? Once a week, drink with a full glass of water, sit upright. You don't have to stand. You could sit and don't go back to sleep, because you're taking it with an empty stomach, right? And people figured, well, I'll take it early in the morning. Um, let's talk about zoledronic acid. That drug is an IV form. It's an IV bisphosphonate. You give it once a year, pretty easy. I give it to patients who in my population, a fair number of them can't take oral medications because they can't swallow and do what the process correctly. They're quite demented, and so but they potentially have many years to live. So I would say, hey, let's just do this once a year, easy, one and done. Osteonecrosis of the jaw would be one of the major side effects. Hypocalcemia, myalgias, and some patients may complain about this flu-like feeling. So we'll tell patients to take some Tylenol ahead of time. Teriparatide also, it's a PTH parathyroid analog. If given low dose, it actually promotes osteoblast differentiation and function. So osteoblasts, bone building, it promotes bone building. Pretty cool stuff. Cost is also very variable with your insurance. It's 20 micrograms subcutaneous, maximum of only 2 years. And we'll talk about why the 2 years. Side effects include nausea, headache, hypercalcemia, hyperuricemia, and hypotension. So basically, these things, if your physician does order it, they will be following to make sure that your calcium, the uric acid is all like in line and that you don't kind of go off the rails. Why do we only give it only 2 years? Well, some years back, there were animal studies done, and they found a type of bone cancer for animals who were, testing this drug. And so it's actually kind of scary. We don't want no bone cancer. But, the osteosarcoma surveillance study actually did a pretty good study where they looked at over 3,800 cases. And of those, they found 1,100 of those patients. And of those, they found that only 3 reported a history of taking this medication. So it's pretty low likelihood. But because the animal study was done and it's there, FDA says no more than 2 years. So you might find that your physician might say, hey, we'll start you on a bisphosphonate. We'll give you a holiday on that drug, and then we will maybe use teriparatide. You might find that your physician might use a combination of things. The RANK ligand inhibitor, denosumab, also called Prolia, that's a trade name. So these are not my pictures, but they're really pretty pictures. So you have to rethink the colors of the cells. And in this case, the osteoblast is blue and the osteoclast is green. Basically, there's a RANK ligand. It's basically a signal that's produced. So remember, body is dynamic. So we would make bone, the osteoblast would make bone, but then you also have these osteocytes. These are bone cells deep in the bone that also would send messages out to say, hey, the osteoblast is working, but we need to start shaving away sites so that we can actually have smooth bone. We're not going to have lumps and bumps, right? So it would send these messages to a precursor osteoclast, to that green cell there. But you see this baby green cell. This is a picture. This is on a rank. It hangs on to this baby cell here called the osteoclast precursor. And it sends a signal to it to say, hey, you need to differentiate. You need to keep forming until you have a full-blown adult osteoclast, which is in 5 here. What this does is it's basic. If you're balanced, it's perfectly fine. But in our situation with osteoporosis, it's not balanced. So what does rank ligand inhibitor do? It's basically a human monoclonal antibody, and it's a activator receptor that actually latches onto the rank ligand, these orange little things over here, these orange rank ligand, and basically it latches onto it. And so it never reaches the osteoclast precursor. So you never develop a osteoclast. Pretty similar method to the bisphosphonates. It's just slightly different. And so basically it helps to build bone that way. It slows bone turnover again. Costs, very variable depending on insurance. Dosing is 60 milligrams subcutaneous, so it's actually injection into the skin every 6 months, and usually given in a specialty clinic, usually given by rheumatology or endocrinology. Side effects, hypocalcemia, rash, serious infections potentially. Remember, this is a monoclonal antibody, and so necrosis of the jaw. This is not first-line therapy. And I want to kind of mention about this medication because a lot of press have come up now. Some years ago, we realized that bisphosphonates cannot be given forever. We had some women who were on it like for 10, 15 years. And then we realized, holy smokes, we're giving it forever. And they're developing fractures, fragility fractures associated with bisphosphonates. So now you might notice, and we've been doing it for the last 10 years, is that we give patients drug holidays. You might be on a bisphosphonate for 5 years, and then we're like, okay, you can stop it. Why? Because we need the bones to kind of turn over. We have to use the body's way of kind of basically turn over and produce, these cells again. We can't keep the bone frozen in time. That's not safe. Denosumab is, and I don't think we really know very much about it yet, but we do know that if you stop it abruptly, you may develop these pretty bad fractures of the spine. And so kind of scary. When this first came out, I think I was in fellowship, maybe in my last year of residency in fellowship, and we thought, holy smokes, this is like an awesome drug, something different. Let's use it. Fast forward like 12, 15 years later, and then we're like, maybe that wasn't the best idea too. So the long and short is all medicines have a plus, big plus, and potential minus. And you want to kind of have this discussion whether you are ready to potentially take Prolia lifetime potentially. It's a potential lifetime. And I think we're learning to see how we can transition patients who are on it to different medications to kind of mitigate the potential for fracture risk. That is actually a little bit beyond me. I think I would defer to our endocrinology or rheumatology specialists on how to do that. But it's just something I noticed I want to kind of let people know because I think one of our guests over here asked me about it earlier, and I said, yeah, I will kind of mention about that. Conclusion, osteoporosis is very prevalent. I mean, we know it's both in men and women, and there are no symptoms until you fracture. So I want you to, consider talking to your physician about, hey, what can I do about screening, which is super easy. And if you do screen positive, what options are there for you? Each person's a little different. And of course, lifestyle, that's something you can do every day. Any questions?
Thank you so much, Serena. We do have a lot of questions online already, so I can
This
start
group
out.
always intimidates me. I see a hand over there.
So here's the first question. Why are most pills for calcium so huge? Hard to swallow.
Yes.
And also, is powdered calcium as good as taking a pill?
I would think so. What we do for a lot of our care home patients, we end up crushing it into a pill form. I don't know. I don't know why. And I think it's just to fit 500 milligrams of calcium into a pill, it just becomes that way. So there's other forms. Soy, you can drink soy products. You could drink orange juice, which is fortified with calcium, milk, yogurt, cheese. Essentially, if you have one serving of some kind of calcium-rich food, whether it be milk, cheese, or some kind of like dairy substitute, it's essentially 330 milligrams, and you just need to do it 3 times a day. You can have ice cream 3 times a day. I don't know about the diabetes, but you can have calcium 3 times a day.
I know they have chewable forms now.
They have chewable forms too. Yeah.
Um,
Oh, yes.
How does Evista work into your medic?
Oh, raloxifene.
Yeah.
It's so raloxifene, if I remember correctly, it is good for spine fractures. I don't recall it for that is actually approved for the studies were approved for hip fractures, but we can use it. So I just kind of picked out the more common ones, but for some patients, depending, maybe they can't use, a different bisphosphonate, maybe they can't tolerate it. So we would use Avista maybe. Yeah. So yes, there's actually more. I just kind of picked out the big ones and the common ones.
Why does my doctor say of those who have osteoporosis, some have strong bone and some have weak bone?
I don't know.
Yeah, I don't know the answer to that one either.
I don't know.
I don't.
Of those with osteoporosis, some have strong and some have weak. I don't
The definition of osteoporosis is weak bone.
Yeah, yeah. I
I'm
don't
not
know.
sure either.
I don't know. I can't answer that one.
Okay.
Sorry.
I'm one of those people who ended up on Prolia, although I resisted it for a long time because I heard you can't get off. So you're saying that they're trying to transition to.
So, I was looking at the literature, and I think for some patients who want to transition off, I think they're looking at how do we transition off? And this is a moving target. Like I was talking to, and how I kind of came about this was like, I was reading it up for this talk, but I was talking to one of our endocrinologists. I'm like, and one of my patients, the daughter insisted on her being on Prolia. And I'm like, is that something we really need to be on? And so I started talking to her, and then in her note, it talked all of it spoke all about the various risk factors, and I'm like, you have to take it lifetime, and stopping it abruptly could cause fractures. I was like, whoa, my eyes got big. I was like, is that what I want to put my patients on? So I called her up, and she said it has been an issue, and so I think there needs to be a better conversation, shared decision making again on what would be, because the flip side is, what if you resist and what if you have a bad fracture? That's a bad situation. The statistics show that if you have a potential fracture, like from a fall, it's almost a 50% mortality within the year. You die within that year, not to mention the disability. So it's always weighing that risk and benefit here, like which is going to be to your benefit. Yeah. And so I think it's something to talk about with your physician. Yeah. Because everybody's individual.
Is alendronate associated with atypical fractures?
Yes, if you're taking it, and that's when I'm saying if you're taking it for a prolonged period of time without stopping. So that's why there should be a time stamp to stop. About five-year mark is when we say it's safe. And it's believed that the medication is kind of still in your body, so it's still working. So that's why we stop it. And then maybe a couple of years later, we might actually get another bone mineral density just to see where you're at. And if we notice that, hey, the bone mineral density scan the numbers are starting to change where you look more osteoporotic, then we have to start thinking, oh, the turnover has turned on again, that we might have to maybe add a different medication. Maybe we put you back on bisphosphonates. It all depends. Yeah.
Thank you. One of the afflictions of old age is obviously osteoporosis, and I'm currently on Prolia. But at the same time, as I age, the dental work that I had 10, 15 years ago are suddenly beginning to either age, or fail, or I need a new
New something.
So whenever I've gone to the dentist, they always ask, "Are you on Prolia? If you are, can you stop if we redo the dental work?" I'm at this point thinking maybe I can go around without my teeth and just walk around with stronger bones. But what is the solution in dealing with some pretty complicated dental work if you're using Prolia?
I don't know. Again, I think this is a moving target. It's so I had braces as an adult, okay, as a physician, and I was talking to my orthodontist and like what do you see when you have patients who are on you see a fair number of older adults who decide that they want braces or they need something, and they say that the bones don't move. So the teeth stay frozen and they don't move. So they actually, even if they try to do braces on them, it doesn't work. So that's why they do ask for patients to stop bisphosphonates. And at that time, Prolia wasn't a big thing. It was just bisphosphonates. So I don't know what the answer is. I think we might have to talk to a dentist, and probably in their dental research, they're going to see a lot more of that because they're seeing older patients on these medications. And I'm sure they have some data on like what to do about that. Yeah.
I'm not sure exactly what this question is, but they are asking about what are I think the pros and cons of injectable Prolia as medication.
Prolia is always injectable.
Yeah. So what are the pros and cons of having it?
Oh, what I talked about earlier, like some of the side effects. I think I said nausea, and I think I said some hypocalcemia. Those are the big ones. Osteonecrosis of the jaw. Again, it has to do with the whole how we kind of slow down this bone turnover process. And of course, the big one is supposedly you can't stop it. It'll be a potentially lifetime.
I know
Yes.
if you take too much calcium, it might cause some kidney damage. And for vitamin, is that the same for vitamin D and is that?
So what does vitamin D and calcium do for you? Vitamin D helps you absorb calcium. So you can take a boatload of calcium, all those big pills, and just get super constipated and not get that calcium into your blood because you don't have D to absorb it in. So you want to kind of take both of them together. You want to kind of take it in different intervals. You can't just take all 1,000 out at one time because the body's limited in its ability to absorb all the calcium. That's why we say like maybe 500 milligrams twice a day, or like you're eating food like 3 times a day. Mhm.
Is there any way to help the body build bones without these medications with side effects?
Oh yeah. The problem with osteoporosis is these cells coming back to the microscopic level where the osteoblasts have slowed down. They just don't really work very well. And the osteoclasts, they keep moving at the same pace. So these medicines help to kind of change that dynamic. Even if you add more calcium and more vitamin D, it doesn't change that process. So that's why these medicines have basically transformed and really decreased the risk of our patients having significant fractures. It does work. We're not giving it for no good reason. It actually does work and it prevents fractures. So I guess the answer is not exactly. I think you can, to a certain degree, you can build bone with your weight bearing and lifestyle, but to truly get to the core of actually slowing that process of these cells and making them kind of slow down in bone turnover, there's no other way.
Regarding the scary comment from the gentleman about not being able to get your dental work,
I know.
you're on Prolia and you're on it for life. What about the other options? Do you
Bisphosphonates?
Yes, can you have
You
your
can
dental
stop it.
work?
You can
Oh,
stop
you
it.
can stop it.
Give yourself a holiday. And it might take a while. It might take a little bit. But you can, so I usually do this. If I'm about to start someone on something, I'll be like, do you have dental work you're going to do? Do it now. And then we started afterwards. Let it heal, started afterwards. So you have to anticipate a lot of these things. Like, want to plan for this. Of course, you don't, like in your situation, you've had it done years ago and now they're starting to fail. So that's a different story, right? But in general, if we're even about to start, I always ask, like, what are the list of things that might occur? Yeah.
So on the other drugs, are they also lifetime? Like you're going to have a higher
No,
risk of
They're
fracture?
not lifetime. And that's why, like bisphosphonates, we have a drug holiday. We actually stop it.
But then
Yeah.
you started again.
We may restart again if we notice that the bone turnover has started to rev up again. It's trying to find that balance, right?
Which is different than the Prolia, which is contraindicated to ever stop once you start, right?
Technically, I'm going to have to read up a little bit more about it. This is like news. Like when we start noticing it, it's like, whoa, what's going on? I think we're still learning. We're really still learning about it. Yeah.
This lady's asking about exercises. Can
Um,
exercise like jumping 100 times daily help?
Excellent.
Or weightlifting? What
Mm.
type of exercises do you recommend more?
Weightlifting is good. I mean, don't hurt yourself. But weightlifting is good. Jumping is good because you're jumping on your own weight is on your own bones. So that's actually a good thing if you can do that. I recognize that some of you may not be able to do the things that you used to do because you're older, right? So you have to, decide on, even if it's a weight bearing exercise, what can be done. At Kaiser, we have a Silver and Fit plan for some of our seniors, for all of our seniors, basically. If you have Senior Advantage Medicare, I think that's what it is. And it's a free thing to like 24-hour fitness. And I'm sure you can find yourself a coach there and they can tell you what things you can do. Yeah.
For many of our folks who can't do very strenuous exercise,
Yeah.
even walking is
Walking.
very good for you. Yeah.
So I have joined OsteoStrong. It's an organization that tries to give you osteoporosis support, or maybe even avoiding osteoporosis by having their support without any drugs. And I will tell you, I broke my tibia and my fibia at the dog park when a couple of dogs ran into me and threw me up in the air and busted up. I mean, really shattered my bones. And a year and a half later, the orthopedic doctor said to me, your bones have replaced themselves. So I've been going to this OsteoStrong for coming up on 3 years. And we just, for half an hour on Saturday, I go over there and do my process with them. I take the nutrients that they have recommended, which is all the things you're talking about. And my bones are perfectly strong. I don't have my balance back exactly, but my bones are very strong. And I have to wait until December because DEXA scan can't be done before 2 years. But there's another method that they have at OsteoStrong that they're introducing. They haven't started it yet, where without using any the radiation of the DEXA scan, they are going to measure our hips and I'm not exactly sure what the whole
What would they measure?
is, but anyway, they will be able to show us if our bones are stronger, and you can take it anytime. You can do the measurement anytime because you don't have to worry about the radiation. And it's something that they've just brought over from Europe. And so it's brand new. It's not even in place yet. But anyway, I just want you to know that there is a facility here on Oahu, the only one, and there are only, I think it was 7 facilities around the United States that actually have this new way to measure your bones. So I just bring it up in case anyone is interested.
That's interesting. I don't know. I'm assuming ultrasound. I'm not sure how would they measure. The radiation that you get is less than flying on an airplane with bone density. So you don't have to worry about that because it's even like it's a very low dose X-ray. So if you've had several CTs, you got way more. No worries about that.
Are you familiar with a bone building supplement called Algae Cal with strontium boost? And what is your opinion of its effectiveness?
I don't know. Do you know, Dr.
I've never heard of
Masaki?
that. Yeah.
No, I actually don't know. We should look at some of these studies. Kind of interesting.
Yeah.
Yeah.
I think my concern about these non-FDA approved, anything non-FDA approved is how well is it studied? You know, that's always my concern because anything that's considered like a nutritional supplement or herbal supplement doesn't have to go through rigorous testing. So hopefully, actually, NIH has recognized that this is an issue and they've created a new institute called the National Institute of Alternative Medicine, I think. And they're trying to do more clinical trials on these types of medications and then give them FDA approval if they are truly effective.
That's actually a good idea. Yeah. Because a lot of people are, the supplement industry is a billion-dollar
Huge.
industry.
It's huge.
Sometimes we hang on people's hopes and desires that they could try something different. Yeah. Question?
Yes, is there like a lifetime limit on how long you can take Fosamax? I thought before they used to say 10 years. And do you just need to take like these drug holidays then from it?
In theory, you can take it for a long time and just have drug holidays in between. So if you think about it, like if you started maybe later in life, what is the life expectancy of this person? So how, I mean, you might have drug holidays, every 5 years, and it'll be a few years. So before you know it, maybe you're only going to be on it maybe 3 times in your lifetime.
Is it okay to have a massage if I have osteoporosis?
Always. I love massages. I think if you have significant manipulation of your bones, then I'll be a little bit concerned. You just don't know what they'll do in moving your spine and everything. That's the only thing. But massage, I think sweetest massage, I'll take it any day.
Do you know if optimizing your gut microbiome will have any beneficial impact on osteoporosis?
I don't know if that would, but I think optimizing your gut microbiome is just good in general. Having a good gut, normal gut where you you're not constipated. I mean, it's just good all around. I wouldn't go out and buy the most expensive of anything. I mean, I looked at, I think I went to one of the supermarkets and I was shocked. The cost was like $1,000 per gram. Like they kind of looked at it per gram and I was shocked how costly it is. So yogurt is just fine. I don't know, it used to be 76 cents per, I think, container Yoplait yogurt at Safeway. That's perfectly fine.
I'm 80 years old, don't smoke and drink, but I exercise daily. I have osteoporosis in my wrists, osteopenia in my hip and spine. My doctor recommended Fosamax, which I took 15 years ago for 5 years. Could I now just take calcium supplements instead of Fosamax?
I would do another bone marrow density. I like to see where your bones are at right now and then make that decision then.
Okay.
Easy, just get the bone marrow density, put in your FRAX score, you're 80 years old, put your weight down, and the FRAX score would pop out a number, and then you can kind of discuss it with your doctor.
I always hear that weight-bearing exercises are good, but what does that look like? Like I asked my doctor and he's like, anything is good, but then I consulted a personal trainer. I'm not part of Kaiser, and then they're like, well, just do this and that. Like, should whatever work I put into it, I want to know that I'm doing enough to make a difference. So is
Mm-hmm.
that like half an hour a day or 15 hours a day? Or you know what I'm saying? Like, where would I even start?
Dr. Masaki, I don't think I recall seeing studies on the number of minutes doing whatever weight bearing. I don't think any, because you know why? That's too cheap. No one is going to do a study like that and then measure bone marrow density afterwards. But I think just think about overall general health, cardio health. Okay. I would love my patients to do some kind of exercise activity half an hour a day. So in that case, build in some weights into that, right? So, if you can do 3-pound weights initially, you can do 3-pound weights. If you can kind of do some, if you feel like you can do some running or jogging, you do some running or jogging. I used to walk a lot with my grandmother, and I've seen people attach weights to their legs. If your balance is okay, you can attach some weights to your legs, so you're actually lifting more than your own leg as you're walking. So that's weight bearing, right? Planet Fitness. I'm at Planet Fitness, and I see older adults doing, actual lifting weights, pulling on the machine. So that's actually, weight bearing. Mhm. So it depends on, I wouldn't, there's no specific time. And to be honest with you, I think most of myself, I'm quite lazy and I just have to make that time to even squeeze out that half an hour.
I've noticed going to gyms that there are more young women participating in weight-bearing exercises like young men who traditionally want bigger muscles. But many older women seem to be reluctant based on social factors. Are doctors encouraging a change in behavior?
Of course, anytime. My population starts at 80 years old and above. Anytime you should go. Yeah, yeah, you don't have to look good at the gym. It's okay.
Do you screen your older male patients for osteoporosis?
I do. I do.
What do you do?
So again, I look at the risk factors. So I didn't mention about the equation. There's this equation here. Is weak bones plus falls equals to fracture. If you never fall, you won't fracture, right? You can have all the weak bones in the world, but if you don't have a traumatic incident, you'll never fracture. So if I look at my patient who maybe is 70 years old and older, who like is having trouble with balance, I start thinking, what is your risk for fracturing? I would potentially go into the FRAX calculator, put all the numbers in and get a sense. And then I say, you know what, let's just go and get a bone density. Super easy, super cheap, covered by pretty much all insurances. And then we take a look at it again. And if it looks like you potentially are osteoporotic, then I would say, hey, it's a conversation because it's work. Taking medicine is work. It's work on you to think about doing it on a daily basis. And so you're going to have to decide how you want to do it.
Can you tell me about the family of treatment drugs which Forteo falls into? And what is the scariest risk, such as long-term use bone fractures?
So Forteo is teriparatide. It's a class in itself. It's a PTH analog. And the scariest risk, well, there's no long-term, you end at 2 years and that's it. And the scariest risk, I guess it's that osteosarcoma, but because of the 2-year mark, we don't ever get there. So you don't get the osteosarcoma. Potentially hypocalcemia, hypercalcemia, hyperuricemia, those lab values. And so that's where your physician would probably want to kind of watch the blood levels closely. Easy blood test. Mm-hmm.
Has anyone ever switched from Prolia to the alendronate?
So I can't answer that question because in my clinic, I deal with mainly dementia patients. And so I would say I would defer to my endocrinology colleagues on how they're managing this part. This is, again, kind of like new situations where some patients who say, I don't want to do this anymore. What can I do? Can it be switched? Yeah.
If you're on Prolia and need dental surgery,
Oh, it's the same question. Yeah.
can you do?
I don't know.
Uh-huh.
I don't know. And I'm going to admit, I don't know everything, but what I can do is I can go back to my colleagues and say, hey, what do you do? What do you suggest? That's why we work in a group, right? In a group practice, we lean on each other and it's like, I don't have all the answers, but maybe someone does.
There aren't any more. I've got more here. If one has had osteopenia for years, is testing every 2 years sufficient at the age of 81? How often do you test?
So this person is testing every 2 years.
They're saying, is that adequate?
I think so. I think insurance only covers every 2 years, I believe. I don't recall it covering any shorter interval. If you're osteopenia at 81, good for you. That's awesome. You're doing something right. Tell us what you're doing. Any other questions?
I have so many more. I don't think we can get to all of them. I think, okay, let's do one last one here. And then I do have one question about geriatrics that I can talk.
Hi, if you have osteopenia, what is the probability of you developing full-blown osteoporosis?
Oh, I don't know. We have any data on the trend on that. I don't know. Do you know, Dr. Masaki? I
I
don't.
know it's a risk factor, but I don't know what rate.
Yeah, no, I don't know what
I think
rate.
you'd have to, if you had osteopenia, I would just keep testing. to
Yeah.
make sure.
And actually, family history.
Yeah.
If your parents had developed it, you may be following that same rate. You might slow it down if you start running. Yeah, exercise, you might slow it down. Yeah. Or changing some of the habits and doing things.
We have lots of questions on the Zoom, but there are too many and some of them are quite long. So I don't think we'll have time to get to it. But there was one question about at what age should I get a geriatrician?
Oh,
That's a really tough one. I would say in an ideal world, everybody who was 65 would benefit from a geriatrician for preventive care. But we are far from an ideal world, and we have such a critical shortage that currently we kind of reserve geriatrician services for the really frail, the very elderly, people with multiple complex medical problems, and people with dementia. Would you say that covers pretty much? what we
it's
do?
even within our Kaiser system, I only have 3 docs, 4th one coming, but we have over 280,000 members. And so if you think about it, I think we have about at least 40,000 65 and over, or maybe more than that. I can't take 10,000 a piece. It doesn't work that way, right? So our primary care docs are pretty well versed, and I think of myself as the sidekick to the primary care. You know, if they have a question, they come and find me. We have many ways of finding me. Through Teams messaging, secure chat. They have my cell phone, email, whatever. If they have a question, they can find me. In geriatrics at Kaiser, we are mainly taking care of mostly the very demented patients with severe behaviors. But you know, a lot of the osteoporosis type arena is handled by our endocrinology colleagues.
Thank you so much, Serena. That was wonderful. Obviously, a lot of questions on this very complex topic.